Hi, everyone. Welcome to the June 2026 podcast. As always, we have a great lineup of papers. I'll be reading you the title, the first author, and the key findings, sometimes the conclusions also, depending upon the type of paper. This is Jeanne E. Poole, and I'm the editor-in-chief of the Heart Rhythm O2 Journal. Welcome. The title of the first paper is A Network Meta-Analysis of Comparative Effectiveness and Safety of Pulsed Field Radiofrequency and Cryoballoon Ablation for Atrial Fibrillation by Dr. Jeanne E. and colleagues. The first key finding is that PFA demonstrated superior efficacy with significantly lower risk of atrial arrhythmia and atrial fibrillation recurrence compared with both radiofrequency ablation and cryoballoon ablation across the overall study population. Second, amongst patients with paroxysmal atrial fibrillation, pulsed field ablation was associated with a lower risk of atrial arrhythmia recurrence in both RF ablation and cryoballoon ablation, whereas outcomes with cryoballoon and RF were comparable. Next, atrial tachycardia, atrial flutter recurrence risk was comparable between PBA and other modalities, whereas cryoballoon was associated with a lower risk of AT flutter recurrence compared to RF ablation. Next, safety outcomes were similar across all three modalities, with comparable overall peri-procedural complication risk. However, cryoballoon ablation was associated with lower risk of pericardial complications. And finally, PFA was associated with shorter procedure times compared with cryoballoon ablation and RF ablation, but longer fluoroscopy times than both thermal modalities. The title of the next paper is Pulmonary Vein Isolation Using a Novel Balloon-in-Basket Pulsed Field Ablation System, the HRO2 Protocol, by Dr. Roland Tiltz and colleagues. The first key finding is that this study provides the first standardized step-by-step workflow for pulmonary vein isolation with optional posterior wall ablation using a balloon-in-basket pulsed field ablation system. Second, the integrated mapping and ablation design enables a catheter-only approach supporting efficient and reproducible wide antral isolation without the need for a separate mapping catheter. Third, procedures were characterized by short duration, low fluoroscopy time, successful acute PVI in all patients, and seamless integration of PWA without relevant prolongation. Finally, the workflow demonstrated favorable acute safety profile and a rapid learning curve, with progressive reduction in procedure time during early operator experience. The title of the next paper is Efficacy and Safety of Atrial Fibrillation Ablation in Patients with Marfan Syndrome, a Multi-Center Analysis by Dr. Hussein Nabi and colleagues. The first key finding is that atrial fibrillation is common in patients with Marfan syndrome. Amongst 979 patients with confirmed Marfan syndrome, 221 or 22.6% had AF or A-flutter, highlighting a substantial burden of atrial arrhythmias in this population. Second, catheter ablation demonstrated limited long-term efficacy amongst patients undergoing rhythm-targeted ablation for AF. 81% experienced recurrent atrial arrhythmias with a median time to recurrence of 0.88 years, and nearly half, or 48.8%, required repeat ablation procedures. Third, recurrence rates were particularly high in persistent AF. In patients with persistent AF, 93.3% experienced recurrence after ablation, and 60% required at least one repeat ablation procedure. Next, procedural complications were relatively frequent. Amongst patients undergoing ablation, 23.9% experienced complications, including bleeding events, pericardial complications, pulmonary vein stenosis, and thromboembolic events. And finally, pacemaker implantation and device-related complications were notable. Pacemakers were implanted in 6.2% of patients with AF and A-flutter, with device-related complications occurring in 23.1% of those receiving pacemakers. Up next is a paper titled Sex Differences in Atrial Fibrillation Treatment with Catheter Ablation in Southern Brazil, Real-World Insights from a Latin American Registry SBRAF, by Dr. Marcelo Braga and colleagues. First key finding is that in this large prospective multi-center registry from Latin America, women represented less than 1/3 of patients undergoing first-time catheter ablation for atrial fibrillation. Second, at the time of ablation, women were older and had greater symptom burden and higher thromboembolic risk scores than men, despite more frequently presenting with paroxysmal AFib. Next, atrial tachyarrhythmia recurrence rates after catheter ablation were similar between women and men during long-term follow-up. Procedural safety was comparable between sexes, with low and similar rates of major adverse events. And finally, these findings suggest that despite differences in AF clinical presentation, catheter ablation provides similar safety and efficacy in women and men in real-world Latin American practice. The title of the next paper is 1- and 2-stage hybrid atrial fibrillation ablation using a biparietal irrigated radiofrequency clamp, a dual-center cohort analysis by Dr. Luca Eretz and colleagues. The first key finding is that hybrid thoracoscopic ablation using a biparietal irrigated radiofrequency clamp achieved high rates of pulmonary vein and left atrial posterior wall isolation confirmed by endocardial validation in both 1- and 2-stage procedures. Second, endocardial validation demonstrated successful isolation in 96.4% of 1-stage and 86.2% of 2-stage procedures, with no statistically significant difference between the two approaches. Third, complication rates were low and comparable between the 1- and 2-stage hybrid ablation strategies. And finally, redo catheter ablations showed durable pulmonary vein and posterior wall isolation, indicating sustained lesion integrity during follow-up. The title of the next paper is Clinical Performance of an Atrial Fibrillation Burden Tracking Algorithm, Evaluation Against Reference Public and Clinical Textile Electrocardiographic Datasets by Dr. Arezou Karamazadeh. The first key finding is the authors state that they developed a lightweight rhythm-based algorithm enabling accurate detection and atrial fibrillation burden estimation using wearable textile electrocardiographic recordings supporting continuous and unobtrusive monitoring in real-world settings. Second, the system achieved high diagnostic accuracy with sensitivity and specificity exceeding 95%, confirming its clinical reliability for identifying AF episodes and normal rhythms. Third, the algorithm demonstrated strong robustness to noise and motion artifacts, maintaining stable performance in both controlled clinical environments and ambulatory monitoring conditions. And finally, the integration of cloud-based analysis with textile ECG technology introduces a novel, scalable approach for continuous AF surveillance and early clinical intervention. The title of the next paper is Circulating Metabolomic Profile and its Association with Atrial Fibrillation and Systemic Inflammation by Dr. Udi Thakur and colleagues. The first key finding that the authors note is that they performed targeted metabolomic and inflammatory profiling in a total of 101 patients with atrial fibrillation and controls with supraventricular tachycardia with analyses adjusted for H-sex of body mass index. Second, they find that interleukin-18 levels were significantly higher in patients with AF than in controls, with the highest concentration seen in persistent AF, and remained independently associated with AF after adjustment for clinical covariates. Next, 9 circulating metabolites differed in abundance in AF, including lower peroxidine, ascorbic acid, and D-glucose, alongside higher medium-chain fatty acids such as capric acid and caprylic acid. Next, B-alanine was uniquely elevated in persistent AF groups compared with both paroxysmal AFib and control groups, suggesting a potential association with more advanced disease. And finally, trimethylamine N-oxide levels did not differ between groups, indicating that its value as a biomarker may be context-dependent and influenced by underlying vascular disease. Next up is a paper titled Discrimination of Atrial Fibrillation Burden using Cardiac Magnetic Resonance Imaging by Dr. Andreas Gasser and colleagues. First key finding is that in a contemporary cohort of patients with atrial fibrillation, only 1 in 4 patients exhibited a high AF burden greater than 10% during 7-day Holter monitoring. A multivariable model based solely on clinical variables demonstrated only moderate discrimination between patients with high and low AF burden. Third, cardiac imaging parameters including left atrial maximum volume index, left ventricular and diastolic volume index, right atrial fractional area change, and LV ejection fraction substantially improved the discriminatory performance for AF burden, achieving an area under the curve of greater than 0.90. Finally, the combination of clinical and imaging variables did not further enhance the ability to discriminate between high and low AF burden compared with imaging parameters alone. Next up is a paper titled Zero Contrast Cardiac Resynchronization Therapy Device Implantation in Heart Failure Patients with Renal Impairment by Dr. Biagio, Sassone, and colleagues. First key finding is that in patients with chronic kidney disease undergoing cardiac resynchronization therapy, a zero contrast implementation strategy was feasible in 57.5% of cases, with iodinated contrast use as a bailout in the remainder. Renal function remained stable with zero contrast CRT, whereas contrast use was associated with significantly estimated glomerular filtration rate decline and a higher incidence of acute kidney injury. Third, contrast exposure independently predicted an equal to or greater than 20% eGFR reduction. And finally, procedural safety and clinical outcomes were comparable between strategies, but even modest contrast use carried a substantial renal risk. The next paper is Impact of Patent Foraminal Ovale on Transvenous Lead Extraction Characteristics and Outcomes by Dr. Aaron Park and colleagues. The first key finding is that the overall in-hospital mortality rate during transvenous lead extraction was significantly higher in the PFO cohort, 5.41%, than the non-PFO cohort, which was 0%, with a statistically significant difference, p equals 0.016. Multivariate regression was unable to be performed to calculate an odds ratio given that there were no events in the non-PFO cohort. Second, the incidence of in-hospital stroke was numerically higher in the PFO cohort at 2.7% than the non-PFO cohort at 0.40%, but this difference was not statistically significant. This remained true using multivariate regression analysis with an odds ratio of 3.81, 95% confidence intervals between 0.18 to 79.38. P was not significant. Third, complete procedural success was 90.66% overall and was lower in the PFO group, 83.78%, than in the non-PFO group at 91.67%. Although this difference was not statistically significant, this remained true using multivariate regression analysis with an odds ratio of 0.43. And finally, a PFO was detected in 12.8% of patients, 37 of 283, undergoing transvenous lead extraction using routine intraoperative transesophageal echocardiograms. Up next is a paper titled Indication Stratified Early Outcomes After Transvenous Lead Extraction in Hemodialysis Patients, analysis of a prospective 1,256 patient registry by Dr. Kuno Shah and colleagues. The first key finding is that hemodialysis patients undergoing transvenous lead extraction have heterogeneous short-term risk based on procedural indication. Next, infection-related extraction in hemodialysis patients was associated with longer hospitalization, but there was no statistically significant increase in 30-day mortality than in non-hemodialysis patients. Third, malfunction-related extraction in hemodialysis patients identified a distinct high-risk subgroup with markedly higher major complications and higher early mortality despite preserved procedural success. And finally, indication-stratified risk assessment may improve patient selection, peri-procedural planning, and referral decisions for lead extraction in hemodialysis patients. Next up is a paper titled Beyond Symptoms, Rhythm Surveillance in Congenital Heart Disease by Dr. Yinglin Su and colleagues. The first key finding is that arrhythmias are highly prevalent in patients with congenital heart disease and are not reliably predicted by symptoms, with comparable rates of clinically significant arrhythmia in symptomatic and asymptomatic individuals. Second, extended 7-day rhythm monitoring improves arrhythmia detection beyond conventional 24-hour Holter or event-based monitoring and frequently results in clinically meaningful management changes. Third, arrhythmia burden increases with age and congenital heart disease complexity, supporting a risk-stratified rhythm surveillance strategy guided by age and disease complexity rather than symptom status alone. The title of the next paper is Pre-Procedural Cardiac Computed Tomography Assessment of Left Atrial Posterior Wall Morphology Predicts Atrial Tachyarrhythmia Recurrence After Cryoballoon Pulmonary Vein Isolation by Dr. Fuminori Odagiri. First key finding is pre-procedural cardiac computed tomography, angiography, or CCTA, derived left atrial posterior wall morphology was associated with atrial tachyarrhythmia recurrence after cryoballoon pulmonary vein isolation. Second, among CCTA-derived posterior wall parameters, left atrial posterior wall circumference emerged as the strongest regional imaging correlate of ATA recurrence after adjustment for conventional clinical and echocardiographic factors. And then third, an LAPC threshold to be equal to or greater than 199.6 millimeters provided effective risk stratification for ATA recurrences across atrial fibrillation subtypes. The title of the next paper is Survival Prediction After Cardiac Resynchronization Therapy, Clinical Scores versus Left Ventricular Ejection Fraction by Joe Demian and colleagues. The first key finding is, in cardiac resynchronization therapy recipients, clinical scores assessed at 6 months, measures of functional capacity, frailty, and health status provided meaningful prognostic information for long-term survival. Second, in nested models, several clinical measures improved discrimination more than the left ventricular ejection fraction, with the largest gains observed for 6-minute walk distance, followed by the study of osteoporotic fractures frailty index, the timed up-and-go test, or TUG, and the 5-level EuroQoL, so EuroQoL 5 dimension. Third, clinically pragmatic thresholds, such as 6-minute walk distance less than 1,200 feet, or frailty index equal to or greater than 2, TUG greater than 12 seconds, gait speed less than 0.8 meters per second, identified higher risk patients and may support structured risk discussion and follow-up intensity. Next, in LVEF-adjusted models, the overall pattern was consistent with the primary analysis. Combining LVEF with multiple clinical measures also improved model fit compared with using LVEF alone. And finally, taken together, objective performance measures and patient-reported health status offers a practical, clinic-friendly framework to refine post-CRT risk stratification beyond echocardiographic parameters alone. An editorial by Dr. Anshul Gupta and colleagues follows this paper. The title of it is Beyond Ejection Fraction, Rethinking Response and Prognostication After Cardiac Resynchronization Therapy. The title of the next paper is The Value of Microelectrodes and Microbipolar Electrograms in Premature Ventricular Complex Mapping and Ablation, the Micro-PVC Study. The key findings are, first, analyzing the relationship among microbipolar, bipolar, and unipolar electrograms, it is possible to infer the depth of the premature ventricular contraction source. Second, when the earliest bipolar signal preceded the earliest microbipolar signal by more than 10 milliseconds, there's a high probability, with sensitivity of 0.94 and specificity of 0.75, of requiring ablation in both the right and the left ventricular outflow tracts for successful PVC suppression. Third, microbipolar electrograms provide superior temporal and spatial resolution compared with conventional bipolar and unipolar recordings, enabling more precise localization of PVC origins. And then finally, micro-EGMs seem to be valuable for local activation time annotation, with important implications on automated annotation algorithms within existing electroanatomic mapping systems. The next paper is titled Premature Ventricular Contraction-Mediated Ventricular Fibrillation, Clinical Characteristics, Application of Machine Learning Algorithm, and Outcomes of Catheter Ablation, a Case Series by Dr. Abhishek Mann and colleagues. First key finding is that the authors state their study analyzed an international multicenter cohort of 82 patients who underwent catheter ablation for PVCs and PVC-triggered ventricular fibrillation, with a control group of patients without ventricular tachycardia. 41 patients were in each group. The patients with PVC-triggered VF had a significantly higher prevalence of 12-lead electrocardiographic abnormalities such as 1, notching of QRS complexes, and 2, early repolarization of either inferior or lateral leads. Third, when the authors applied a machine learning algorithm called factor ECG, they observed that it had a reasonable level of discrimination between the two groups of patients with the area under the ROC curve of 0.85. Next, explainability analyses identified anterior ST segment deviation and a left bundle branch-like delay of the ECG waveform as salient contributors to the machine learning-based prediction model. Finally, after a median of 1 ablation procedure per patient, 82% of patients remained free of sustained VTBF and implantable cardioverter defibrillator shocks over a median follow-up period of 400 days. The next paper is a design paper The title is Centers of Excellence Optimal Management Pathways for Atrial Fibrillation Specialty Services, COMPASS, Early Rhythm Control Treatment Care Pathway Equality Improvement Initiative by Dr. Rupinder Sandhu and colleagues. The first key finding is that the early rhythm control has been shown to improve atrial fibrillation-related morbidity and mortality. Delays often exist to translating evidence into clinical practice. Second, the Heart Rhythm Society's AF Center of Excellence Task Force designed the Centers of Excellence Optimal Management Pathways for Atrial Fibrillation Specialty Services program to improve the implementation of evidence-based practice. Third, this is a multi-center pre-post study of recently diagnosed patients with AF within 12 months, conducted at 3 different healthcare systems using site-specific customization of intervention delivery for the early rhythm control treatment care pathway. We thank the authors for submitting this design paper, and we look forward to seeing the results of it down the road. Well, the next paper is also a design paper. The title of the paper is Persist PWI Trial Rationale and Design of a Multicenter Randomized Controlled Trial Comparing Pulmonary Vein Isolation Alone with Pulmonary Vein Isolation plus Posterior Wall Isolation using a pulse field ablation in patients with persistent atrial fibrillation by Dr. Yasuo Okumura and colleagues. First key finding is that in persistent atrial fibrillation, routine posterior wall isolation has shown inconsistent and incremental benefit with thermal ablation, partly owing to limited lesion durability and esophageal safety constraints. Second, pulsed field ablation provides preferential myocardial injury with relative sparing of adjacent structures, potentially enabling safer and more durable posterior wall lesion sets. Third, the Persist PWI study is an investigator-initiated multicenter randomized trial comparing pulmonary vein isolation alone with PVI plus PWI using pulsed field ablation in symptomatic drug-refractory persistent AF in Japan. Third, mandatory pre- and post-ablation FARA view-guided mapping enables mechanistic assessment of lesion completeness and procedural reproducibility. And finally, rhythm outcomes will be assessed using structured follow-up with Holter monitoring and biweekly or symptom-triggered portable electrocardiography transmissions. And again, we thank the authors and we look forward to the results of this study. Next up is a research letter. The title is Lessons Learned from an Integrated Mapping and Ablation Catheter by Dr. Christiane Jungen and colleagues. The key findings are first, pulmonary vein isolation using an integrated mapping ablation variable loop PFA catheter achieved high acute procedural success with a favorable safety profile. Second, procedural efficiency improved during early clinical adoption with reductions in mapping and left atrial dwell times, reflecting a measurable learning curve. Third, left atrial anatomy influenced procedural workflow with larger atria associated with a longer mapping and dwell times. And finally, anatomy-adapted catheter maneuvers, particularly for the right inferior pulmonary vein, facilitated successful ablation in challenging anatomies. The next paper is another research letter, and the title is Cardiac Screening in Adolescents, Insights from a 15-Year Student Heart Check Program by Dr. Ty Metzger and colleagues. The first finding is over a 15-year period, a comprehensive cardiac screening program, including electrocardiography and echocardiography, evaluated 15,761 adolescents aged 13 to 18 years, identifying abnormal findings that warranted clinical follow-up in approximately 10% of participants. Second, those advised to stop sports participation showed significantly higher rates of syncope, ECG abnormalities, and structural heart disease. Third, among students with available follow-up data, clinically significant diagnoses included Wolff-Parkinson-White syndrome, long QT interval, left ventricular hypertrophy, valvular disease, and conduction abnormalities. And finally, the prevalence of serious conditions such as WPW detected through screening was comparable with that reported in the general population, supporting the potential value of adolescent cardiac screening. The third and final research letter has the title Duplex Ultrasound Assessment After Venous Vascular Closure of 16 to 17 French Outer Diameter Femoral Venotomy, the Amulate Expand Ultrasound Substudy by Dr. Jared Bunch and colleagues. The first key finding is that in a core laboratory adjudicated duplex ultrasound substudy of 29 evaluable patients after Vascade MVP XL closure of 16 to 17 French outer diameter femoral venotomy, 89.7% showed no abnormal DUS findings and no subject required intervention for detected abnormalities. Second, 3 abnormal findings, or 10.3%, were detected: 2 partially occlusive common femoral vein thromboses at 6.9%, and 1 hematoma for 3.4%. All were asymptomatic in a high-risk, fully anticoagulated cohort. Early post-procedural duplex ultrasound confirmed preserved venous compressibility and respiratory phasicity in the vast majority, supporting that the device maintains early venous integrity and aligns with low complication rates reported for other large bore venous closure strategies. The final 4 papers are letter to editors with response to those letter to the editors for 2 individual separate papers. So that ends the June 2026 podcast, and I hope you all enjoyed listening to our lineup for this month, and we'll talk to you again in July.